Hello, I'm Dr. James R. Golding, and you're watching A Natural Healthcare Alternative, the show dedicated to your health, longevity, and well-being. Tonight's topic is reproductive endocrinology and in vitro fertilization. This is the first of a three-part series of programs that deals initially with introduction to IVF. The second part of the series is on suggestions to follow for couples undergoing IVF or in vitro fertilization. And the third part of the program will be the use of acupuncture as an adjunctive alternative means of medicine along with IVF in its treatment. With me tonight are two renowned and well-known doctors in the field of reproductive endocrinology, Drs. Saleh and Drs. Dlugi of the Center For Reproductive Endocrinology located in Bedminster, New Jersey. Doctors, welcome to the program. Welcome to Natural Healthcare Alternatives.
Thank you.
And I'd like to start the program out tonight by having you each tell a little bit about yourselves and about your educational background.
Did my undergraduate training at Yale University, received my medical degree at the University of Pennsylvania, did a long residency at the Johns Hopkins Hospital, did a fellowship in infertility and reproductive endocrinology at Yale University. Subsequent to that, I was on the faculty at Harvard Medical School as well as Tufts University School of Medicine. Went to Detroit, where I ran the Division of Reproductive Endocrinology for the Henry Ford Hospital, where I had the pleasure of meeting Dr. Saleh when he was a young resident. Was there for 7 years, was recruited to Morristown Memorial Hospital in Morristown, New Jersey, to develop a program there, and after 4 or 5 years opened the Center for Reproductive Endocrinology in Bedminster, and was fortunate to have Dr. Saleh join me again after many years.
That's quite a background. And Dr. Saleh?
Well, I did my residency in OBGYN at Henry Ford, which is where I met Dr. Dlugi. Then I did a 3-year fellowship at Stanford University in California. And then I came and joined the program here.
Well, I think that you guys are certainly well qualified to be on the program. Is it my perception, or are more couples in need of the nature of the services that you provide as far as reproductive endocrinology?
And I think the percentage of couples with infertility has been fairly steady, running at somewhere around 10 to 12% of the population. I think what's happening now is that it's no longer a stigma, and people are talking about infertility issues more openly and are coming to see people such as ourselves more frequently.
Yes, there was an increase many years ago with the 60s. We did have an increase in tubal factor infertility, but this has stabilized now, so the access has improved rather than the percentage of people with infertility.
How significant is a woman's decision nowadays? Women are seemingly having children or wanting to have children later on in life, whether that be just they're becoming married later, or they've decided to be on a career track. Has that significantly impacted the people that come to see you, the women and couples that come to see you?
I think it definitely has. I think our average age patient is 36, 37 years old. Some who've never been pregnant before, others who've been pregnant once or twice, and are now again at a later stage in their lives trying again but having a problem. And certainly as you look at pregnancy rates and outcome, there's certainly a lot of data showing a declining chance of success as women do get older.
Mm-hmm. At what point should a couple who have been attempting to have children unsuccessfully on their own come to see you, or when should that enter their mind?
It depends a little bit on the age group. Someone who is less than 35, also to come back to what Dr. Dlugi was saying, the fertility will go down with age. And so someone who's above 35 years old, we will address the issue sooner. Let's say after 6 months of inability to conceive on their own, that would be an appropriate time to seek help, versus a younger couple who may have tried a year, for example, without conceiving.
Okay. What would be some of the primary reasons why a woman would be infertile?
There are a number of reasons. First of all, just to clarify something, about 40% of infertility problems are related to the female, 40% to the male, and the remaining 20% is a couple issue, meaning that one or both couples may have something wrong. When you look at things from the woman's end, the main problems are tubal problems, ovulatory problems. There may be a problem with endometriosis. Those are the more common things that one sees. More rarely one sees problems with cervical mucus. There may be a problem with the uterus itself. And then about 10% of couples have so-called unexplained infertility, where after going through all of the conservative types of testing, one really comes up with nothing. And there really is no good explanation until you get into something like in vitro fertilization, where we may find an explanation for why a particular couple is having problems.
Mm-hmm. You know, that's very interesting, because I would have thought, when you mentioned that 40% female, 40% male, just in my own mind, I would have thought that that all of the mechanical processes and chemical processes that are necessary to go on in the women, I would have figured it to be a greater percentage of where the potential problems could lie in being infertile. Now, what about for the male? What are some of the main problems there?
I would say the main problem for the man would be something called a varicocele. To put it in other words, that would be the equivalent of having a varicose veins around the testicles, and so that would affect the ability of the testicle to produce good quality sperm. They are outside the body for a reason. They have to be at a cooler temperature to be efficient in the sperm production. And so when there are varicose veins around the testicles, that can increase the temperature and then affect negatively the sperm production and quality.
Now, is that a similar process to what they call strangulation? Is that something different? That
yes, that
is
would be
that's a different.
Although, I mean, I think apropos the varicocele, most men don't have a varicocele, and oftentimes it's really unexplained why there may be a decrease in their sperm count, or the motility of the sperm, or why they look funny. And of course most men want to know, gee, why? Is there something I can do to fix all of this? And unfortunately we know much more about female reproduction than we do about male reproductive ability.
There has been a trend actually towards decreased sperm count over the decades. We're not sure if this is an environmental effect or not.
I had heard some very simple things, like the difference in men wearing boxer underwear versus using briefs can impact that to some degree, or whether a man goes frequently into a hot tub, decreasing the sperm count. Are there any other, big lifestyle things that they found out that could influence that? Your drug use, illicit drug use.
Absolutely. Just a comment on the boxers. We always get those questions, and the comment that I make to people is, if your underwear is so tight that your voice goes up a few octaves, that's a problem. But other than that, it really isn't. Now, sitting in a hot tub for hours on end, or in a sauna day after day, yeah, that's a problem. That can affect sperm production. I'm sorry, the rest of your question was?
Well, or whether they found additional lifestyle things that exterior factors.
Certainly the use of alcohol in excess is a problem. Smoking is detrimental both for the male and the female. Drug use, marijuana in particular, and any of the narcotics in excess are a problem. And of course, there's some patients who are undergoing chemotherapy for cancer, and many of those types of drugs are also detrimental to reproduction.
Mm-hmm. Now, if I were a couple making a decision to come into, and I had an appointment in your office today, and we went into your office, what would we expect? What would we expect to go through? Let's say we came and we got all of our records, our past medical histories together, our everything, the gynecological records, anything that we could that would be potentially of value to aid you in along the process. What are the procedures? What are the step-by-step steps?
Well, we like to start with the semen analysis again, to come back to the fact that that single test will rule out
one of the easier things.
We'll assess 40% of the story, so that simple test can tell you half of the story.
Mm-hmm.
And so we would start with that before we move on to the examination of the female partner. And the most important would be an X-ray of the tube, what we call a hysterosalpingogram, to make sure that the tubes are patent on the female side.
Now, is that done? That's a small camera that's
This is done
inserted into the fallopian tube.
This is done in a radiologist's office, and so that will be the insertion of a dye, and then the X-ray is taken, and if the tubes are open, patent, then the dye will flow and spill freely into the belly.
No obstruction
right.
or anything like that.
So this is a non-invasive way to assess how patent the tubes are. It does not always tell you everything about how functional the tubes are, but at least how patent they are.
How is the dye put in? Is the dye put in through
the cervix?
Through the
So
cervix to see whether that goes up in there.
Yes.
So there's step-by-step process. So what next?
Well, things have changed over the years. We have trimmed down a little bit on the amount of testing. Some things have not turned out to be very cost-effective. So these will be the two most important. And then there is a whole debatable number of tests.
I think also to answer your question, typically we'll have a couple come in. They'll spend a good hour with one of us, reviewing the history, physical findings, what previous testing has been done. And then we really tailor our approach really to the couple's desire. Are they looking for, gee, we really want to know why we're not getting pregnant, and let's spend some time going through all of these types of tests? Are they more at a point where, gee, we've had a lot of these tests done and there's no point in repeating them, and let's move forward? And there are some couples who will come in, fed up to here with everything, and let's move fairly quickly, and please do something for us that's going to get us pregnant.
Mm-hmm. An action step, right?
Yes.
You're looking for an action step versus a diagnosis step.
And the approach has changed over the years. If you had asked me even 10 years ago how we would have done something, it's very different from what we're doing today. And the reason is primarily that the success rates with in vitro fertilization have changed so dramatically. To give you an example, when I was a fellow at Yale, we were the second program in the country to start in vitro fertilization. And we were absolutely thrilled when we had a pregnancy rate of 7%. And we had couples who tried, 3, 4, 10, 15 times going through IVF with a very low success rate. Today, on the other hand, depending obviously on the circumstances, we're looking at a 50, 60, 70, even an 80% pregnancy rate at our center. And so to go through a whole rigmarole of testing and sometimes useless testing and drugs and surgery really isn't very effective anymore.
What have you found to be like the average duration of time? I realize that some people may need to go through the process a few times to become pregnant, but is there like a global average between when a couple comes to your office and the achieving their goal of getting pregnant?
I think if the couple choose a very conservative approach, it could be 3 months, 6 months, a year. If they're going into something like IVF, typically from the time we see them to their IVF cycle, I would say is about 2 to 3 months. And honestly, 85% of our patients who conceive with in vitro are pregnant on their first attempt. So our patients don't stay with us too long.
No, that's a pretty awesome statistic.
To add something, we are very sensitive. You have to understand that these are not life-threatening problems, and so the patient is really the person driving this, the couple. And so depending on what couple we're dealing with, we might go faster or slower. And so if we go too fast on someone who wants to be conservative,
Right.
they might get frustrated. So we're very sensitive to that as well. And you don't want to be too conservative on someone who's impatient, because then they'll be frustrated as well.
Yeah.
So the patient is what
So
who
you have
drives
to
this.
feel that,
Right.
feel that out a
Our
lot.
role is to explain to the patient what all the alternatives are and what are the success rates, and then the couple makes the decision themselves.
It's almost like the, how much how much desire the salmon has to swim upstream may vary from one couple to another. How long is an IVF cycle? A singular cycle. What is that duration of time from,
Typically, when we see a patient for the first time, before they get to in vitro, the cycle itself, there's a preliminary testing phase. We're required to do certain things by the government because transferring embryos is considered tissue transplantation, so there are certain rules that have to be followed. So, for example, we'll screen for HIV and gonorrhea, that type of thing, and it takes about 3 weeks to pull that preliminary data together. Once a patient is actually ready to do her cycle, she undergoes about 3 weeks of injectable drugs. During that time, we may see her 3 or 4 times for monitoring to see how the ovaries are responding. She has a retrieval done. 3 to 6 days later, the embryos are transferred. Then the worst part is a long 10 days waiting for the pregnancy test. So it's about a 3 to 4 week period.
I feel like I'm getting my own personal lesson right here. This is really good. The delicate and intimate nature of your work, which is the balance between science and sensitivity, how do you walk that bridge with your patients? And it's such an emotionally charged issue, as well as the science life side of it. How do you walk that walk?
It's difficult. I think one of the things we try to do is to really maintain a very personable environment in the office, friendly, warm. We're not one of these factory types of programs, so there's an awful lot of individualized attention, not only from us. We're probably one of the few programs where the doctors actually called patients back with laboratory test results, explaining everything along the way. We have a very warm and supportive nursing staff. I think our whole center was actually built to give a sense of warmth. It's I wouldn't call our offices sterile by any means. We looked at nice muted earth tones. It's warm, it's soft. Our offices were designed not to be these imposing, sitting behind a massive desk type of a thing. And it's really meant to give a sense of we're really approachable and we're there to talk to our patients
I
and
think
be available.
I think that for couples and especially for women, that is such a crucial issue. That's such a crucial issue from things that have been mentioned to me.
I think this is a field where the science has moved a little bit away from the examining room or the operating room. It's become more and more a laboratory-oriented field. So it is very important at the physician level to retain that,
to not lose touch with
that human touch, and patients will appreciate that a lot.
I think
a lot of people of our patients complain about being a social security number in a program where you have hundreds of people. No one knows the nurses or the doctors, that they don't see the same doctor. So we try to use science to have more time to talk to our patients. So everything is computerized, everything is streamlined in the background, so that we have more time to sit down instead of having to write notes.
Well, I know just starting up an operation like with what you do, there's a tremendous amount of resources that you need. It is not, there's a tremendous amount of people, resources, and it gets to a really important question that I have, which, what type of new advances have there been recently that might allow a couple that was unsuccessful with IVF before to have hope that IVF may work for them now?
I think one of the fascinating things that we have done really started in September when we had a new embryologist join us. He used to work with me actually in Morristown. And what he has done over the last few years is actually customized his own culture media, meaning the actual fluid that these embryos are growing in. And so we make it fresh on site. It's not store-bought, one size fits all. It's actually customized to every single patient. So there may be several patients, let's say, who are cycling at the same time and they have an egg retrieval. Each one may have a totally different culture media. It's customized to her age, to her FSH levels, and actually to what the embryologist then sees on a day-by-day basis. So there may be a little more salt and a little more pepper in one person's, a little more garlic powder in another person's culture media. And what this has allowed us to do, actually, which is we find just absolutely fascinating, is we're now able to grow our embryos out an extra several days to what's called a blastocyst stage.
Mm-hmm.
Now, blastocyst culture is done in other centers, but it's typically reserved in other places for women who are 32 and under, who have at least 6 8-cell embryos on the third day in culture. And the reason is that with standard culture media, you can lose 60, 70, 80% of the embryos going those extra few days. So you better be starting off with a lot of good ones. And what we have found with our culture system is that even with 1 or 2 embryos on day 3, we are getting probably 90% of our patients are moving forward to the blastocyst stage. And as a result of that, we are able to select out truly the very best embryos. And I'll give you a very interesting story. We had a patient who came to see us. She chose to do the blastocyst culture. We retrieved 6 eggs. They all fertilized. On the third day in culture, she had 3 8-cell embryos, 2 6-cell embryos, and a 4-cell embryo. Now, had she done the transfer on day 3, we would have picked the 3 8-cell embryos. They look nice. They're the most advanced. We took her through in culture, and on the 5th day in culture, those 8-cell embryos had progressed to a blastocyst stage. But there was one problem. Not a single one of them had what's called the inner cell mass, which is the actual fetus beginning to form. So had we transferred those on day 3, she either would not have conceived or she would have miscarried. So we chose not to transfer them. She was totally distraught. We said, hold on a second, you've got 3 more embryos. They're a little slower, but let's see what they do. On day 6, she had 3 more blastocysts. One of them again lacked the fetal component, but the other 2 were beautiful. And we transferred those that had been a 6-cell and a 4-cell originally. She's pregnant.
That's pretty incredible. It demonstrates the degree to which the science has advanced, in the behind-the-scenes action, as opposed to just regulating the hormones, waiting for a certain day, like a rote process going on. The whole thing of the culture medium and, allowing that specimen to be able to get big enough where now if by pushing it out days, is there a greater degree of adherence to the uterus when they're older?
The implantation rate appears to be better, the pregnancy rates. I mean, since September, among the women who've done this extended culture across all ages, including some 43 and 44-year-olds, we have an 80% pregnancy rate.
Now, does that culture also take samples of the woman's the pH of the woman's mucus in the uterus, or I mean, does that type of thing? It's all just deals with the, you know.
Well, I mean, the science is now played at the microscopic level and molecular
which is
level.
amazing.
Right.
Which is amazing.
Which means you're right. We are controlling for the pH, the acidity, the osmolarities, the temperature, the humidity. Everything is controlled, and we have up to 42 parameters in this lab. The air purification system, all of these are advancements that are making those embryos able to grow longer. There are a few other techniques that I wanted to bring up, not so new but important nevertheless, because within the last few years we're now able to do microsurgery on these embryos. And so if, for example, a male had bad quality sperm, you would be able to handpick with a microscopic instrument. You would then selectively handpick the best sperm. Or let's say if someone had only 5 sperm, you would just take those 5 sperm and inject each one into the microscopic egg without damaging the egg, without damaging the sperm. That would then allow that sperm to fertilize the egg into an embryo. So this has revolutionized the treatment for male factor infertility. We no longer need those millions of sperm that we used to need when we were doing standard in vitro fertilization. Something that not all programs do also is something we call assisted hatching. A human embryo, like a chicken embryo, has to hatch and crawl out of his shell or membrane for humans and then attach to the lining of the uterus. So in those women who have an H factor or who have a poor egg quality, those so-called unexplained infertility in the past, we're now able to detect those under the microscope and make a small opening through the shell right before we transfer the embryos, helping those embryos hatch on their own. And this is something we do as well with our extended culture media. We do some kind of microscopic...
Yes,
Doctors, I hate to say it, because I hate to leave right now, because I've learned more about this whole process in the past half an hour than I've learned in totality. Doctors Saleh and Dlugi, thank you very much for coming today. This was an extremely informative program, and a lot of the viewers are going to get a lot out of this. For Natural Healthcare Alternatives, I'm Dr. James R. Golding, and thanks for viewing.